Good afternoon, everyone. I'm Zach Kacharski, the Gazette Executive Editor based here in Cedar Rapids. Welcome and thank you for joining us this afternoon. And thanks for your patience as we work through a little technical fun when we have panelists around the state and there are thunderstorms in the area. The internet slows down a little bit. And so we were working on getting a quick restart there. Today is day 3 of our in-depth week with the Children's Mental Health System. Today's topic, we're going to be talking about intakes and assessments as a piece as we continue to dive in. This is day 3. Tomorrow we look at the criminal justice system, as well as then on Friday we conclude our series with the children's mental health in schools is the final topic that we take on. You have opportunities to ask questions and use the Q&A at the bottom of your screen. Those questions will get routed to us and we'll work them in to the conversation here today. And those questions will be filtered to us and we'll work them in. As well, I'd like to say a special note of thanks to our in-depth week sponsor, Tanager Place. They have been generous in putting together sponsorship for this in-depth week as we work towards the Iowa Ideas Conference coming in October. I'm joined today by Gerta Bardoshi from the University of Iowa and Michelle Smith from the Quad Cities Autism Center, and I'm going to ask each of them to give brief introductions of themselves. I think they're in a better position to do that than I am, and we'll take the conversation from there. Gerta.
Hi, everyone. My name is Gerta Bardoshi. I'm an associate professor in counselor education here at the University of Iowa. And I'm also serving as a director of research and training for the Iowa Center for School Mental Health. I am both a licensed clinical mental health counselor in the state of Iowa and a certified school counselor. And my area of expertise is actually assessments and how do we use tools to identify children with mental health risks, and how do we use tools to kind of help us really hone in on the diagnosis. And I'm really excited to be here today.
Thank you, Gerta. Michelle.
Hi, my name is Michelle Smith, and I am the director of the Quad Cities Autism Center here in Moline, Illinois. We serve the greater Quad City area and serving both Illinois and Iowa residents. We have been serving the Quad City area for the past 16 years. We are exclusively an applied behavior analysis clinic that serve children that are diagnosed with autism ages 2 to 10. And more importantly than being the director of the Quad City Autism Center is I am also a parent of a now 22-year-old boy who has autism and has been the strength behind what I do every day, and certainly my passion and encouragement. So I kind of have a little bit of a foot in both doors, both in clinical and certainly in parenting.
Thank you, Michelle. Kind of as a starting block question, I'm curious, Gerta, I'll start with you. When we talk about intake and diagnosis tools, there's been some talk at the state level about a universal intake tool. And I'm curious, as we enter the system today, how diverse does it look? Are there benefits and are there challenges with universal tools? Obviously, it gets people speaking the same language in various providers, but then humans are involved, and so there's probably some challenges there as well.
Yes, absolutely. And just to clarify, Zach, are you asking specifically about universal screening in schools?
Yes.
Yes. Yeah. So this is kind of, it's a national conversation is really kind of picking up around the importance of screening students early on to identify potential concerns. And schools are a natural setting. Students spend a lot of time of their day in schools, and it's become sort of something that we are really trying to best prepare. What are the best tools in order to do this? And I just want to clarify, when we're talking about universal screening, it's not using questions that are diagnosable, right? So it's kind of like, think about it, you are sort of in a forest and you see maybe some smoke rising up. And that's what the screening does. It just sends out signals that there might be a concern. You don't know for sure if there is a fire, how big the fire is, how quickly it's spreading, right? So the role of the universal screener is to just identify if there is potential for emotional issues or inattention issues or behavioral concerns or academic concerns. So then we know, okay, there's some smoke signals here. We need to follow up with a closer, more precise type of assessment that can lead to diagnosis. And I also want to clarify schools. School counselors don't diagnose mental health concerns. That's not the role of the schools, but schools can be at the forefront of identifying students who need additional support and then making those appropriate referrals so then a diagnosis can happen quickly and then they can identify what kind of treatment a child might need.
Girta, just kind of staying on that track, obviously working with kids and it probably presents a unique set of circumstances. How much does that change early on versus by the time you're preteen? That's probably a different experience.
Yeah, 100%. And I will say we don't have very good tools to identify before age 12, right? So, and there's a conversation about, it's so important to identify them at like the 6th grade, 12-year-old level. You see that's the start of adolescence. Over 50% of all mental health concerns happen around the 14 to 15 year of age. So 12 makes sense. But we don't have tools really that have been tested and developed for children much younger than that, because they're relying a lot of it on self-report, right? So students say, this is how I feel most of the time. Well, developmentally, that requires, even for adults, that requires a lot of self-understanding and self-awareness and kind of wherewithal to be able to identify some of those things. Another best practice is to use teacher report and parent report. And there are some very good tools out there that have been identified and developed for parents and students and teachers. So ideally, what you would like to do is get all 3 of those reports and then identify, okay, are they matching? Is there a concern? But that takes time and resources, and that can also present challenges in and of itself.
Michelle, I was curious, in your introduction, you mentioned working with kids from age 2. What is the age breakdown of the folks that your facility serves, and does it skew to that kind of 12-year?
Well, we typically work with children 2 to 10. So that's the age group that we work with. I would say the median is more around 6 or 7. A lot of it has to do with diagnosing, because we do typically serve children who have already got the diagnosis of autism. You don't always get the opportunity to have a young child, 2 years old, to get that diagnosis. But obviously, when that occurs, that is best case scenario, because we all know that early intervention is such an incredible key to long-term, good prognosis and good outcomes. But we occasionally have those very, very young ones, but I would say 4, 5, 6, 7 is probably that more general age that we're working with here at the Autism Center.
And if I could follow up a little bit on that, Zach, kind of how Michelle indicated, we tend to see autism diagnosis fairly young because there are some behavioral markers, there's some things that are pretty hard to miss. So as a parent, as a teacher, you have an indicator, this child needs additional support. It's not always the case with, let's say, depression or anxiety. Those are pretty internalized type situations where a child first might not be aware of what it is they're experiencing can be problematic, or might not want to say, or doesn't feel comfortable sharing. So the screening hopefully tries to get at some of those things that tend to be a little bit more hidden.
Geert, I was also going to ask, there's maybe a hesitancy among some providers to label or to make a diagnosis too early on. How often does that come into play? And even when you're working with schools or some of the work that you've done, is that something that you've seen present there, and what impact does that have?
Absolutely. And I am a mental health professional, but I think labeling and diagnosing young children without necessarily putting in the time and the clinical thought into it can be dangerous. So I understand where parents are maybe a little bit reticent about that, or schools are like, do we really want to do this? And I just want to highlight some of the tools that we use for universal assessment. For example, there's one that's called the Strengths and Difficulties Questionnaire. So it really stays away from any kind of labeling. It's looking at what are areas that are strengths, what are areas that you need additional support. So it might have something like emotional problems as a category, but it's not specifically saying this child is dealing with major depression, right? So I think when we're talking about screening, we're just really looking at potential areas for additional concern. But, you know, the diagnostic interview is the classic gold measure. We would hope that then a child meets with a licensed and certified mental health professional to do a full diagnostic interview, to get parent report, to get teacher report, to consider the environment, the child's developmental level, the child's strength in forming a diagnostic picture. So a diagnosis is not something that can happen, you know, after filling out 20 minutes of a survey.
You know, one of the things that we also look at is that, I don't know whether it is particularly parents of children with autism, but there's almost a sense of relief for some of our parents when that diagnosis comes through, because I think it becomes the new starting point of now they have something to look to do and something to study and something to kind of dig deep. And so often it also can be the gateway to services. So often when those diagnoses do come through, we find that families have that kind of almost relieved feeling of like, now what? And then especially, you know, when we get incredible diagnostics that come out of the Iowa clinics, the hospital, and with such incredible, you know, resources and referrals and information that I think they take that document, and then when it's brought to us, we're able to kind of take from that point and move on. So there's just a really nice partnership when proper diagnosis and proper evaluation is done, especially by a larger disciplinary team, when you've got speech pathologists and psychologists and occupational therapists all looking at the child in a very holistic way. That gives us incredible information to then be able to look at that child then very specifically and individually and move forward.
Earlier in the week, we kind of talked about the status of the children's mental health system in the state, and the panelists described it as still in kind of a patchwork, and they're members of the board that's working to build the mental health system. And so they said we're not there to a whole comprehensive system. I am curious about access and kind of, you know, who gets access to some of these assessments. Is this something that, you know, it is easily accessible right now, or do additional measures, or should additional measures be put in place to improve access?
Yota, do you want to answer that particular one? And I can give my view of once it gets to the Autism Center.
Absolutely. I think access is a big issue. Access to mental health services is a big issue. We see there's a socioeconomic barrier sometimes to children receiving access to mental health care, not just mental health care, care in general, health care. So I think that's why there's so much support for this universal screening idea, is that everybody goes to a public school for the most part. And if we're doing these screenings early, we might be able to catch some potential concerns, then we can refer to get a formal evaluation if it's needed. But that also presents challenges, Zach, because as you said, we have a patchwork system in Iowa. So a lot of rural places don't have referral sources that they can send a child to do the type of diagnostic excellence that Michelle just described, right? So it does become an access issue, and it's something that is a concern, because we see when access is improved, when stigma is removed, then children do tend to get sort of the best resources. But those are challenges we're dealing with in the state.
Yeah. I think there's nothing worse than when you have to look to a parent and say, I'm sorry, your insurance doesn't cover this level of assessment or this particular service. I think that's one of the most heartbreaking things as being in the mental health, and child providing services, is that you don't ever want to turn anybody away due to funding,
No, absolutely. And I'm curious, Gerta, when you talk about early on, if you could design a screening system, how early? I mean, obviously today kids go through the hearing tests and some of the vision types of screens. What age group would you be looking at to work with?
Ideally starting at 11 makes sense because, we're seeing some reports about maybe for some girls, puberty is happening a little bit sooner than in previous decades, about, 3 to 6 months sooner. So I think that 11 years of age kind of captures kind of the very start of adolescence. So 11 on makes sense. There are some tools that have been validated with students 11 on. Another component of this is making sure that our pediatricians have access to screening questionnaires that they can use. And there is one that I really like. It's called the Pediatric Symptom Checklist. And it has just a checklist of symptoms that a pediatrician can ask in their well visit. A lot of kids get well visits that can help maybe identify some of these concerns. So if we do it from the school side and if we do it at the pediatrician's office, both of those entities working together, then the chances of catching something early really improve.
I was also curious if how would you assess the school system's willingness to get involved in this space? Is that something that is evolving? There's been some mention of post-COVID, maybe there's much more recognition. What are you seeing?
There's definitely post-COVID was a big kind of catalyst, I think, for us finally believing that mental health concerns of students is a big issue. And I think those of us that were in mental health kind of always operated from that knowledge. But I think COVID and the media attention around some of the mental health concerns that kind of emerged post-COVID during the pandemic has really crystallized a lot of people around this issue. The biggest challenge for schools is, do I have the resources? Do I have the training? Do I have the time to do this? And then also, what if I identify a student who has concerns? Then what? Then who am I going to send them to really figure it out? And also, am I liable if I am identifying a concern and there's nobody to kind of provide services? So, I mean, those are real questions and those are real challenges, but I think schools see that this is a concern. Teachers, we hear from teachers everywhere that mental health concerns of students is one of those concerns that they have in the classroom, and it makes teaching more complicated. So I think schools get it. I just think it's a resources and time and training, and of course, provision of services type issue.
I want to put a pin. I'll come right back to this, but Michelle, I'm kind of curious with your experience, with the education system, how with those that you're providing service for, how engaged are you once you've got that diagnosis and working with them? Have you seen a shift in kind of the educator acceptance or willingness to kind of be involved?
Are you talking a kind of more of like a collaboration? You're sort of curious
Yes.
about more of the collaboration between like school districts and like, say, an individual private clinic like our own?
Correct.
Yeah. I think teachers are amazing. I think that they enter into this industry because they want to help kids. And when they have children in their classrooms that have autism, they really want resources and want to do right by their kids. So we have so often teachers that come even on their own time to the Quad City Autism Center to follow their students or to watch a student, observe a student before they're even going to be in their classroom. And they're very open to gaining resources, as much information as they can. I mean, I think that there can always be improvements in systems that can make collaboration easier. But our overall experience is that teachers want to do right by their children. They're a special group of people, and we really can work well together.
Excellent. Gerta, I wanted to kind of come back to the who at schools, and a lot of times some of the children's mental health services come through AEAs or some of those shared services that aren't necessarily the straight on school district. But I'm curious from an assessment standpoint, what are you seeing, and then who would need to be in place to to conduct these types of assessments?
Yeah, we see a big difference between school districts with a lot of support and a lot of resources and rural school districts. The AAs certainly play a very large role, but we have school districts as well that have, and they employ school counselors, they have school psychologists that they have access to, and they've worked maybe with universities or centers, and they're able to identify questionnaires that they can use. The Iowa City Community School District is an example. They are using an assessment for universal screening. They have lots of resources and lots of support, and they're implementing that. The AAs have a role. That's the role of our center, the Iowa Center for School Mental Health as well, is to help address some of these gaps and help identify tools and best practices and training for schools. So that there's multiple ways potentially and multiple resources that schools can pull on to do this. But it's still, I do also want to say to Michelle's point, teachers are amazing. School administrators are doing, that they are working with in some pretty challenging situations and some lack of resources. So this is not a schools don't want to do this issue. It's how do we help schools do this well?
Well, and so much of this is individualized to one-to-one. I would imagine that presents its own, you've got a support team and it's different for each individual case. And, I think whether you have paraeducators involved and just the involvement of the family too, I think there are a lot of factors that are determining. I am curious, some of these situations with children's mental health kind of evolve over time. And I'm curious, how much from those initial assessments, understanding the forest, Gerta, you were talking about kind of, are there signs or are there individual markers that are there? How long, can you, or how much change do you start to see in some of these assessments over time?
Yeah. Well, the Diagnostic and Statistical Manual is what we use to kind of help us understand criteria. And that has changed the year. So you see updating of the assessments to be able to kind of match that. We have a good understanding now what is internalizing disorders, so depression, anxiety, and externalizing disorders like conduct disorders. So you'll see some reflection around that. You see inattention. Certainly since ADHD started becoming an issue that parents and educators and mental health professionals all got around, you see inattention and impulsivity kind of being reflected in some of these assessments. Something that I think is changing now is we're seeing an increased suicidality rate in students and younger ages as well. So a lot of screening tools don't necessarily have a suicidality question. And we're seeing more and more emphasis and more people saying, we also need to include that as just a basic level screener. Have you in the past couple of weeks had any thoughts of killing yourself? And that's kind of a scary question to think about putting out there for all students, but we really see cases being missed between that year, 12 years of age to 14 years of age around suicidality. And we know in Iowa, suicidal ideation has increased and attempts for suicide have also increased. So that's become sort of a really important issue to kind of get around.
Absolutely. And when you talk about some of these assessments, the frequency in which they would be repeated, so around suicidality, how frequently, would this be an annual type of check-in? I know there have been other kind of question sets that go to students in the state. And is that, another kind of measure that would work?
Yeah, ideally we would like to see this repeated every year, right? So there is a screening every year. But even if there is a screening every year, let's say you fill this out in September and then some things kind of happen around April. And if there isn't any follow-up, you could see, right? So it would be ideal to get this at least once a year. it's not going to solve everything, right? Obviously, because there's some things that might develop. So that's why, training, hiring school counselors, training teachers maybe to pay attention to some of these red flags and ask a question and refer to a school counselor, reducing the school counselor to student ratios. Right now in Iowa, it's over 400 students per one school counselor. And the American School Counseling Association recommends a ratio of 250 students per counselor. So those are all things that can happen in addition to the screening to help catch some of these concerns in students.
I was going to ask, obviously workforce is a question, and we're in a period of low unemployment, and seeming it's difficult to find enough people to fill the different positions. I am curious, what do you see, each of you see as kind of that pipeline? Are you able to find enough folks in the pipeline to be school counselors or to take some of these roles?
I'm just to answer for my side, it has been a struggle. We've been used to for the last, been here 16 years, and every year graduation time, we would have just such an influx of young, psychology students that had recently graduated from the local colleges, dozens and dozens of applications. And we're just not seeing those kinds of numbers, and it's surprising because this field is amazing. I mean, you get to see changes in children every single day. It is such a fulfilling career. And it's disappointing to not be able to fill those slots. And not only from a staffing point of view of like the business, but the wait lists grow when we can't fill those spots. So, the sooner that we can have staff, come in and get the training, and not that we want to move that faster than what's appropriate, but those will change wait lists. I do not like to tell a parent that they have to wait 18 months to be able to receive services from our center because of staffing shortages. It's heartbreaking, once the diagnosis has happened, and there's so many steps along the way to finally get to that place where they have that diagnosis, and then to be told there's another wait list for you now, and that's due to a staffing issue. It's a problem.
And just to clarify, Michelle, is there a wait list? You mentioned 18 months. Yeah.
I mean, we currently have about 30 children that are waiting on our wait list to be able to be served. That's pretty much been ongoing for the 16 years that we've been here. We've had a fairly large wait list, and it's always, one of it is I'm more interested in the quality of services than simply quantity, but that's not something that you want to tell a parent who's waiting on a wait list that's like, I want to get in. But we have to make sure that the quality of services is high. But yes, we have always had a wait list ever since we opened our doors.
And we're seeing similar rates with therapists that sees children around 6 months in terms of wait lists in the community. So, I mean, these are challenges. At the same time, we see people are interested in school counseling, and they're interested in becoming clinical mental health counselors. And there is a large demand. I have a colleague, Barry Schreier, who's actually the director of the higher ed arm of the center, and he talks about a bottomless need. It just seems like our usual pipelines are not meeting this demand, and that we are seeing increased demand. So that's certainly, there's opportunities there to potentially train more mental health professionals, and especially mental health professionals that are specialized with children, because I think that's a really important specialization. And like Michelle said, there's nothing better than working with kids, and you see change so much quicker too. Yeah. Not to rat on the adults, but and we do need specialized training, because the set of skills is different. And you asked about developmental level, and kids express themselves differently, and there's differences in how you approach children. So that training absolutely needs to be there.
Gerta, I was also going to ask, just to the rural issues, is the center doing anything to address some of those balances of students, or to serve the rural communities better?
Absolutely. So we are opening a clinic, actually, a mental health clinic that is going to serve students. It will be located here in Iowa City, but we're also exploring telehealth services as a potential resource. We also are identifying doctoral students that are first years that are interested in school counseling, school psychology, counseling psychology, clinical mental health counseling, family therapy. And we are getting those students trained on school mental health, so they have a specialized set of knowledge and skills. So we're doing some of those approaches. Obviously, it takes time, right? It takes about 4 years to graduate with a PhD, but we're starting those things. And the clinic is going to be operational in the fall.
Okay. I was also curious, kind of flipping gears a little bit to the support networks that you need, and I'm curious. It would be logical that those who have parents that are active and involved, that outcomes may be different. And how important is that support network in terms of, whether it's honing in and getting a better, clarity on the diagnosis versus even just progress? How foundational is that? And
it's certainly huge when it comes to children with autism. And I can't speak outside of my scope of expertise.
Yep.
But with children with autism, we have parent trainings weekly. We set parents up to be successful. We kind of call them the team captain of everything, because they're the ones that need to be able to gain skills to be able to help their child outside of these clinical experiences and clinical times, and prepare them for the future, prepare them for those transitions that are going to occur, because they're the one that's going to be with that child through the duration. So the buy-in from the parent is imperative, and we have a lot to do with how well that goes by the way that we conduct ourselves in including the parent and making them feel welcome in our facilities, so that it's enjoyable to come into the facility and learn and see themselves learn, and then be able to generalize those skills and then be reinforced by being able to talk about those positive experiences. So it's the be all and end all for us.
Yeah, it's absolutely, this translates to kids with diverse mental health concerns. We know parental support is huge. It's funny because the number one protective factor is having a secure and stable relationship with an adult. And a lot of times parents are that adult, but not all children might have access to that support. So that's why we know teachers or school counselors, adults working in the school can also serve that role. I also want to say there's so much focus on parents and parents supporting children. And I also want to say parents are also struggling themselves. Certainly the effects of the pandemic, the economic effects, the mental health effects, the stressors, so I also think that parents need outreach and need support as well. So we all need support. I think that's the message, is we all need support. And if we have support, we all do well, but children especially need that adult support.
Yeah. Just speaking about kind of what Iowa in general is doing in regards to that, our waiver systems are quite amazing. I'm a recipient of, my son is a recipient of waiver services, which offer respite to parents. So that the fact that I have two different roles, two different hats, that I'm a parent to a son who is very affected with autism, these waiver services that are being provided really do help. And the case managers are absolutely amazing, very attentive, very aware of the needs. So we in Iowa are ahead of the game in a lot of ways in regards to what we are offering for both children and for the parents, like Gerta had made mention of.
Gerta, we had a question that came up with regards, I'm assuming it came when you mentioned the opening of the clinic in Iowa City. And the question was around transportation help for families that may need to come across the state to access those services. Is that something that is being thought about as you're putting the plans in place for the facility in Iowa City?
Yeah, we're actually collecting information and data about what kind of supports we need to be able to provide in order for parents and children to access our services. We know that we are limited geographically because we are here. That's why telehealth is something that we're exploring. We're also sending teams of counselors to individual schools that have asked for support. We've done that in Tipton. We've done that in Fairfield. We've done that at Waverly Rock. So we're also trying to get some of our therapists on the different sites of the schools that might need additional support, not just expecting people to come to us.
Excellent. I am curious, if you had the ability to change one thing within the children's mental health system, or maybe the goal of the next year, what would it be? If there were policy changes, if there were practice changes, what do you see as kind of the most pressing issue that you would like to see addressed?
I don't know that I can come up with just one.
That's fair. That's fair. You don't have to pick.
Yeah, I mean, the waiting is the hardest part. So I would love to see just an influx of great people into our fields that are just ready to change lives and make a difference in a child one day at a time. They're going to be fulfilled. Children are going to grow, and we can cut these wait lists. So I'd have to say that the waiting time for all of the different steps to be able to get the treatment that our children so desperately need is, I guess, the major factor I would like to see changed sooner than later.
Oh. And I was going to say that, Michelle, so you grabbed my question, my answer, but also the other thing I would like to see is preventative measures being put into place. Schools are a great venue for that. How are we preparing students to deal with the anxieties of life? Growing up is tough. It's not easy. Adolescence provides mental health challenges for a lot of students. And some of those are okay, they're developmentally appropriate and normal. So I also want to normalize, if you feel like everybody's looking at you and judging you and you're a 14-year-old girl and you are on social media, guess what? Everybody is looking at you and potentially judging you, right? So, and we know developmentally adolescents feel, there's called the fishbowl effect, right? Where they really feel like everybody's watching them. So that presents challenges that are normative, they're part of the growing process, but do you have the skills? Do you have access to supportive adults? Do you know how to reach out for help? Those are the things that I would like to see change. So students are not suffering in silence, and they have some coping skills that not only will get them through school, but hopefully prepare them for the rest of their lives.
COVID seems to be a point in time where there was a lot more isolation, and I'm curious if you're seeing kind of after effects, Gerta, coming to the surface now, maybe a couple of years after, and maybe in the years to come, that may still be something to watch for. But do you think COVID had an impact there?
Absolutely. Early in the pandemic, we were trying to kind of put out some messages out that, taking some time, a little bit of time off from school. I think this was, during spring break, a lot of schools had moved to online instruction. The idea was coming back in the fall, we were all going to go back in person. And, as it became more and more evident that this was becoming from the long haul, we already had some concerns about, and by saying we as mental health professionals and experts focusing on children, had some concerns about what might be the developmental challenges of not having students interact with kids their own age, learning in a group environment. There's so much social learning that happens in schools. So yes, they have definitely, we're anecdotally seeing some effects. There's some research that is coming out that are saying, students did feel like there was increased isolation. They felt like they didn't have some of those developmentally necessary interaction that happened with other children and with teachers in group settings. You also need to think about schools offer financial support for so many students, access to food, food, access to a safe environment, and certainly for students that are in situations where there's violence in the home or there is drug and alcohol use in the home, we're seeing some of those effects really being compounded by the lack of access to daily in-person school.
I would imagine the current economic conditions with inflation and everything else is continuing that, even outside of maybe the formal pandemic, but just the concerns about, costs suddenly spiking for food and other things. So I would imagine that would continue for the foreseeable future. Michelle, we had a question that came from those watching, and it is in regards to the waiver that you mentioned. What home community-based service waiver is a child with autism eligible for? Do they have to have an intellectual disability diagnosis to access funding, or is there another waiver?
I can only speak in regards to what my own son, who had severe autism and an intellectual disability, was able to access, and that was the intellectual disability. There are waivers, though, that are available, especially in the Quad Cities areas that different clinics are able to utilize for funding. I would just suggest that you talk to Department of Human Services and learn what you may be eligible for through that, because I don't know through the broad spectrum of all the options. I just know that the intellectual disability has been what our family has been able to utilize for both respite and for some supported community services.
All right, thank you, Michelle. Gerta, I wanted to ask, some of your research that you've done has been, determining, best practices, and I think you were involved in a high school project recently in which it was meant, to kind of, the students ended up feeling more isolated than they did. And I was curious if you could kind of talk about that project and then what that's led to.
Yeah. I believe the project you're talking about is we utilize Photovoice,
yes.
Which is a technique where you ask students to take pictures of their lives, and we ask them to take pictures of their lives at home and at school. And we would meet with them for about an hour every week for a duration of 10 weeks. And they would come and share their stories and share their photographs and connect with each other. And we specifically work with students that were Latino, Latina, they identified as Latino, Latina, and also were identified as being academically at risk. And these were high school students. And one of the hypotheses in starting this intervention was that the more we have students talk about their lives, the more they see school as a supportive place, the more embedded or the more connected they're going to feel into their school. And I do want to say that was an effective intervention because we saw psychological benefits increase. So students, their sense of psychological well-being went up as participating in those groups, but also these were students of color, and there are students that were identified as not meeting academic expectations. So sharing some of those stories, they started to feel more connected to the in-group, but potentially less connected to the school as they started realizing, well, this is not just happening to me. This is happening to other students of color. And we feel sort of cut off both academically and socially from some of the larger school environments. So part, sort of your question was what came out of this is we created posters with a student photograph and quotes, and this was right before the pandemic, as the pandemic hit, but we presented them at the high school, at the community college in that community, we presented them at the library, we had art shows here in the University of Iowa as an idea to increase awareness of some of the experiences that students of color are experiencing in rural schools.
And I'm curious, one of the reasons that I ask is, will you go back and measure kind of progress over time? And is that something in research along these lines that happens where you check in, you drop in, age 11, 12, even in the high school experience, and then follow up later in life?
Yeah, so we had plans of going back into the school, but then COVID happened, and that sort of kind of removed some of that opportunity. The idea for the project was to highlight this method, the Photovoice, as a really effective method to get students to engage. First of all, to share about their lives at school and their lives at home. To get them engaged in some advocacy, because you ask them, what would you like to change? And then we presented that information to the school in terms of what they would like to change. And the school did make some changes in terms of how they were educating students that were academically at risk. So the point of the study was to kind of highlight to other school counselors, to researchers, to people in the school, kids at this age are just really dying to be heard. They really want their voices. First, they want to know that if they speak to you, you're going to do something about it, and that you value their voice. And if you invite people to share their experiences, and you value their perspectives, it improves the psychological well-being. And it's an effective way to do that in schools.
I am curious, Gerta, you mentioned the liability question early on, or the concerns about that. How do you overcome that? I want to hear them, I want to value their voice, I want them to feel heard. How do you counsel folks to be there if they're needed?
Yeah, and is this sort of, what if they're presenting some challenges that are difficult to overcome? Or help me understand sort of where are you going with the question?
I mean, to me, it's one of those questions of, I think, is there a hesitancy for folks to get involved because there is the concern or the, okay, well, I have a laundry list of things in my classroom. Is there a concern that how do you get past that?
I understand. Yeah. It's like, do I want to open up this can of worms right now when I am exhausted and I have a number of things that I'm trying to finish? And I think, the liability of not doing that is then things happen. Students act out, maybe towards themselves or towards others. And we know that providing students with a supportive environment actually improves not just their psychological well-being, but their academic standing as well. We know that a positive school climate leads to better academic outcomes. And that's what the charge of schools is, right? To get students to learn and to be successful citizens in our world as they grow up. And I just think it's imperative to do that. And that's why the question then becomes, well, what are the best ways to do that? So you're not wasting your time trying to figure out what are the best ways, what are methods, what can you do with this? And then also, how do you promote change in your school environment and convince the other adults that listening to students and hearing them actually has benefits, and it's something that we need to do.
One of the other questions that I think is out there is the metrics or measuring, how do you know if there's a positive outcome? Gerta, are there things that you're seeing schools put in place to kind of measure or to know, to that climate question, hey, these are effective, or that we are seeing appropriate improvements?
Absolutely. So the state does the conditions of learning survey that's asking about things like bullying and support. So already the state is collecting that data. Also, schools have been reaching out to the Iowa Center for School Mental Health to develop assessments that measure specific climate questions, and also that measure specific social and emotional learning competencies. So when you have a concern, are you able to identify your concern? Are you able to ask for help? Do you feel comfortable in asking for help? And the same thing for teachers. Are you able to teach in a way that supports students' social and emotional learning? Are you asking for their feedback in the classroom? When they're presenting a concern, are you following up with them? Do you feel connected to your students? So those are all assessments that we're putting into place. And the idea is we've already distributed it in several schools. The idea is then we would provide some professional development for teachers, and then we would measure that again to see if things have improved.
So just a quick question on that front is, are the schools that are most active, I mean, is the hope to get this in front of all schools in the near future? And is this more like a pilot phase, or how do you see this evolving?
So yes, this is a pilot phase, and we're hoping to be able to identify a brief survey. Right now, I think in the pilot phase, I think it was over 100 questions that so the teachers had to respond to and students had to respond to, and they did an amazing job. But we want them to, spend maybe 5 to 10 minutes answering what are the key questions that are available. So any school that is interested in digging a little bit deeper on school climate or on social and emotional competencies has access to these free tools that they can then distribute. And it's an easy kind of look at before and after.
And what are you seeing in terms of, I know you were very positive and districts want these types of things. Are you seeing a lot of adoption of this, or is it kind of as folks learn about it?
Absolutely. So we're working really hard to fast identify, what are those key questions, because we know once we make it available to all districts, the demand is going to be large. And we're seeing really great things. And these are rural schools. It's not just urban schools that are reaching out for this as well. We're seeing, despite the challenges, students for the most part feel connected to their teachers, and teachers for the most part feel connected to the students, and they try to treat each student equally, and they try to tend to their emotional concerns and their academic concerns. So we're seeing some really good things, but also some areas where potentially we could do some more training or provide some additional support to improve that.
Excellent. And is the time frame, is this something that you're hoping to get in place in the next year, or?
Yes, yesterday.
Okay. Well, I would imagine that's everybody's answer to that. Yes.
Yes. We were hoping to get this ready in the next year.
Okay. And I'm curious, when you measure relevant outcomes, and I'm curious, is this something that happens on the individual level, to know if the diagnosis and the plan is showing progress? I'm curious, how often is this something that needs to be adapted kind of as you go? And Michelle, I'm curious, is this something that you get that initial diagnosis and, you work the plan? You mentioned kind of the starting point to learn, but how often are you going back and revising, and hey, based on these outcomes, maybe we need a slight alteration here?
Sure. That's an awesome question. And I think I'm really lucky to be in the field of autism, in that we're reviewing these continuously. So, what's nice is that you have that initial assessment. And so you have a child who they've gone through the evaluation, you have a comprehensive report that comes back, and they've given those baseline levels on all of those different areas. And then they come to, say, us, the Quad City Autism Center, where we then run our own assessment and look at, okay, across communication skills, across social skills, and across repetitive and ritualistic behaviors, where does this child fall? What barriers are there? What skill levels are there? And what are our biggest priorities? Well, then we devise that individualized treatment plan for that student. And so then you have the board certified behavior analysts who are regularly, daily checking in with these learners. So we don't have large gaps between those assessment periods. Now, we do formal assessment every 6 months. And then generally commercial insurance companies will require that the child be then formally reassessed every 3 years, which again is excellent because it's an individual assessment. It's not done in-house by the provider. And so then you're able to clearly see all of those changes that have happened from that original assessment and comprehensive assessment that was done, say, at Iowa City Hospitals. And then we've had the privilege of serving them and looking and making adjustments continuously, weekly, daily, towards reaching those goals. And then, reassessing formally every 6 months. And then that child will go back 3 years later, maybe, for another formal assessment. Wonderful if they can see the same provider. And there's this independent progress report that is just amazing. And we're very supportive of that sort of thing because, again, we can see all the little movements that lead up to the very big changes.
Excellent. And I know that we're kind of approaching the end of our hour together. And so I wanted to kind of, ask, you just got us to insurance. And so we probably could spend another hour in that space as well. But I am curious, from an insurance standpoint, are there reforms that need to occur, or how supportive is the insurance and those that are maybe on Medicaid and other providers? What type of insurance issues are you seeing?
Well, right now, we are unable to get Medicaid to cover a lot of the private services that are at our facility. We are continuing to work and try to become in network with Medicaid. So often I have to say that it's not that we don't accept Medicaid, it's that we haven't yet been, been able to utilize, been accepted to be able to utilize that insurance. Insurance is great when you have it, although the high deductibles can knock a family out. I mean, we have families here that have deductibles that are $7,500. So here they are, they're paying the monthly premiums and the fees, and then they still have a $7,500 out of pocket. So, again, insurance is great when it's great, and it's really can be challenging when those sorts of things come up. We also find it difficult that sometimes insurance companies are able to dictate what we can provide and what we can't. So I think, again, someone who's outside of meeting this child professionally or personally is saying, no, you can't provide that, or that's too expensive, or no, that's not part of our policy. And I think that can be very, very frustrating. And we just have to keep working ahead and coming up with innovative ideas to show insurance, what these children need and how this is imperative and important. And oftentimes we get a win, and insurance will work with us on those kinds of things.
How do you get to innovate in that space? I mean, that's got to be a really challenging environment to some degree.
We often get the opportunity to speak to the insurance company. And so we'll call in a treatment plan and have an opportunity to really talk about that child on an individual basis. And when they'd say things like, well, are those hours really necessary? We can give, baselines and improvements and give clear data and research of why we're making those changes. And when we're able to do that on a one-on-one basis, we often are able to make those changes and come up with a compromise that is fair.
Okay.
Just to kind of add to that, this is forbidding for a small mental health business. So if you have a small mental health office, if you have a small business and you don't have the people available to call insurance companies to negotiate with them, sometimes what we see sadly is people make the choice. It's easier to not accept these types of insurances because they also do not pay you. There's not enough parity. They might say, well, the services you provide, they only are worth this much. So if you want to provide these services to children, we're only going to pay this much of your time. And that can, if you are a small business owner, that you have a small private mental health practice, that can put you out of business very quickly. So this is a big concern. It's a business concern. It's a mental health concern. It's a parity concern and a mental health access concern. I think it cuts across different areas.
Well, and on top of that, it's what you pay later in life if you don't address some of these issues early on. So, well, Gerta and Michelle, I appreciate your participation today. And for those that tuned in, we've reached the end of our hour together. I appreciate your insights and thank our audience for their participation as well. On behalf of the team at the Gazette and the IYDeas team, we continue to add programming for the October conference at IYDeas.com. Would encourage you to register there for free. And we appreciate you taking time to join us today on children's mental health. Tomorrow, as I mentioned earlier, we will be looking at law enforcement in the courts. And then Friday, we conclude the week-long series on children's mental health in schools. On behalf of the Gazette team, thank you. Have a great day.